Dr. Gopinath to chair the session. Welcome, sir. He's a senior diabetologist and physician, Gopinath Diabetes Center, Madurai. I would like to welcome Dr. P. Mohammed, Professor of Medicine, Madurai Medical College, excellent teacher, an academician, and my very best friend and senior. Welcome, sir. Over to the chairperson.
Good afternoon, friends. At the outset, I would thank the organizing committee for this occasion, with the chairperson for a very important three-speaker session in the afternoon. The topics to be covered in session are vaccination and diabetes. Diabetes patients are more prone to infections than the non-diabetics, so vaccination and diabetes deserves for a discussion. And diabetes in young. Once we thought diabetes is a disease of 40 plus. Today we see a lot of young diabetics. Young diabetics less than 40 years. 25 to 40 years we see a lot of diabetics. And what is the spectrum of diabetes in this age group? To highlight, we have got Dr. Krishnan Swaminathan from Coimbatore. Of course, glucose monitoring, which is AGP and CGMS, body limitations. So we got three. First topic is vaccination diabetes. To deliver on this, we have got Professor Natarajan. I think he is the son of the soil, so doesn't need an introduction now. He is the HOD and Professor of Medicine, Rajaj Hospital, Madurai Medical College. And of course, he's got a lot of publications, and he's got a Best Doctor Award, District Collector, Best Medical Officer Award, Star Doctor Award, newspaper, and Principal Investigator for SMA Plasma Therapy. Also, I personally know him because I always appreciate his clinical acumen and presentations. Over to you, sir.
Thank you, sir. President, good afternoon, all of you. I would like to thank Kumar and his team for giving me this wonderful opportunity. Because mainly I think I am one of the few physicians who are practicing or promoting adult immunization. We have given some few talks on adult immunization so far. So I think knowing that has given me this topic. At the end of the session, I think you will also be convinced that adult immunizations are must, as important as pediatric immunization. So going to the vaccination diabetes, they are neglected necessity. So as and when you are treating diabetes with all drugs and anticipating complications like kidney disease, peripheral neuropathy or retinopathy, you should anticipate infection and prophylactically give vaccine. So that is the main crux of today's presentation. And with the blessings from Meenakshi, I am proceeding with my presentation. So something about microbiology, vaccination and toxoid. You have to understand the difference between these two. Vaccine is a preparation that is used to stimulate the body's immune response. And it can be given via needle, via nasal route sprays. Some vaccines are available as sprays like influenza vaccine, or it can be even given administered orally like oral polio vaccine. So the route doesn't matter. But at times it matters because when you give through nasal route or oral route, there's a chance that mucosal immunity increases and herd immunity also increases. So sometimes we prefer those vaccines given by other routes other than injections. And toxoids are nothing but they are all clinically altered bacterial toxins. Toxins are such they are noxious, but once you convert into a toxoid, they remain the antigenicity, but they are not infectious. So tetanus toxoid, diphtheria toxoid, they are all called toxoids. So the basic difference between vaccine and toxoids is modified toxin is toxoid. And the basic about active immunity and passive immunity, active immunity you get by infection. That is natural and that can be lifelong, but at times there is a chance that it wanes with the age. So you may have to give a booster, you cannot have a booster infection. So second way of active immunity is vaccination, what we are artificially giving. And passive immunity is either indirected through maternal antibodies where the fetus is protected from certain infection at least transiently for 1 year till the antibody wanes. Or when the patient is immunocompromised wherein we cannot give active vaccine, we are going for passive immunity by giving immunoglobulins, monoclonal antibodies. Those are the basics of vaccination. And these are the different responses. So when you get an infection for the first time, you develop a primary immune response, which is IgM, and later the IgG also mounts up. Once you give a booster dose of the vaccination, there's a mounting up of IgG. Both of them are protective. But sometimes the antibodies can be counterproductive, as in dengue. So, the primary dengue and secondary dengue. Primary dengue is just like that, benign viral illness. And only secondary dengue, because of the antibody dependent enhancement, IgG will be more, the patient will develop all complications. So sometimes it's a double-edged sword. So only vaccination in dengue is entirely different story. We give vaccination only for seropositive individuals, once who developed already dengue. We never give vaccination in dengue for seronegative individuals. So why this adult vaccination concept has come up recently very well. The first important thing is to protect against diseases that adults are more vulnerable because of their medical condition. So one such medical condition is diabetes. That means all diabetes should receive certain vaccine. So particular diabetes are prone for herpes, zoster, pneumonia. So because of their vulnerability, that's the main reason for adult to be vaccinated. Second is patient must have received a vaccination in childhood. All of us must have received. But because of immunosenescence, there's a decline in the antibody titer and decline in the cell mediated as well as humoral antibody. So if you give one more prick, that will act as a booster. So that to sustain the antibody response and T cell response perpetuate. And third will be to lower the risk of complications. So certain vaccines need not protect you absolutely from infection. Particularly herpes zoster vaccine, which is recently available, it does protect, but even if it doesn't protect, the worst complication, post-herpetic neuralgia, disseminated herpes, all these things are, it comes down once you give a herpes zoster vaccine. And fourth important indication in adult is to benefit from newer vaccines, particularly COVID. Because in previous era, we didn't have COVID at all. But now there's a COVID, and now current CDC recommends this year also you should receive once COVID vaccine. So these are newer vaccines which are not available in the next decade. And the last is once you travel probably to South Africa or as other places, you may have to have yellow fever vaccine. So these are the indications for the necessity for adult immunization. And as our chairperson pointed out, diabetes are they are vulnerable to most of the infection because of hyperglycemia, because of decreased immunity, impaired lung function, pneumonia is quite common. They have got pulmonary microangiopathy, so increased cholesterol. So most important organ to be protected will be what vaccines available will be lung. And urinary tract infection is also second important organ wherein the patient develop very many incidents, but there is no approved vaccine for that, which I will tell you in the end of the topic what vaccine is recommended for recurrent urinary tract infection. With that, we can classify must-have vaccines for diabetes. All diabetic, irrespective of the age, should have pneumococcal vaccine, influenza vaccine, hepatitis B vaccine, tetanus, COVID, herpes zoster, RSV. These are the must-have vaccines for all diabetics. And I'll start with pneumococcal vaccine. So, in general, in adult immunization, all adults with geriatric immunization by 65 years of age should receive pneumococcal vaccine. But between 19 to 65, we have got comorbidities like diabetes, alcoholism, smoking, congestive cardiac failure, CLD, CKD. So most of our patients, because when they step into your clinic, their patient will have at least one of this. So ultimately, even before 65, you should give pneumococcal vaccine to these people, or increase risk of meningitis, CSF leak, cochlear impairment. So, but our diabetic comes under this category, 19 to 65 years of age, irrespective of the type of diabetes, they should receive pneumococcal vaccine. And now currently I've got two types of pneumococcal vaccine. One is polysaccharide, that's called 23, and another is conjugate, that is 30. Only these two are available in India. Abroad we have got 15 and 20 extra. Now how to go about with this vaccination in a diabetic? The basic difference between these two is conjugate vaccine is supposed to be very superior because it can be used in infants, and the efficacy is 73% compared to polysaccharide vaccine. And moreover, it, as I told you, it's a mucosal immunity, and third effect is more common with the conjugate vaccine. So the current, if at all, if PCV20 is available, I think in another 2 or 3 years in India, that single shot of PCV20 is enough. So no need of confusing. If PCV20 is available, single shot of PCV20 is enough for that, for any diabetic. But till then, what you are going to do. Since 20 is not available, you have to first give PCV 13. Then after 1 year, you have to give PPV 23. So this is the current consensus in all diabetic, irrespective of the age. Pneumococcal vaccine, conjugate vaccine 13 should be given probably on day 1 itself once they step into your clinic as a diabetic. Then after a gap of 1 year, we give 23. And if he is vulnerable, if you have got other COPD or other lung issues, we can give one more booster dose of 23 at the end of 5 years. Then till 65. After 65, one more 23. So the current recommendation is 13 first, after 1 year 23. If necessary, a booster after 5 years. That is in simple about pneumococcal vaccine. And whether he has suffered from pneumonia or not, that doesn't matter because there are antiviral strains. So even a person who has suffered from invasive pneumococcal disease should receive a pneumococcal vaccine because that doesn't protect against all the other strains. So that is about pneumococcal vaccine. And second is, all of us are aware, but find it hard to practice. And before ending the pneumococcal vaccine, you should know the cost also. 13 costs around 4,000 to the patient, and 23 costs around 1,600 to the patient. So that is the cost of pneumococcal vaccine. And influenza vaccine, the current quarter group costs around 2,000 to the patient. So, and why pneumococcal is enough if you give once in lifetime. But influenza vaccine you should give every year with season for 2 reasons. One is antigenic drift and shift. The same strain doesn't come in the second year. So there's a change. So WHO will announce this time it is Brazilian strain, California strain, Venezuela strain. So for that purpose, you have to keep in touch, and the current strain with that vaccine alone you should use. Second is, even if the strain is same in this year also, the durability of protection is around only 9 to 10 months. So even for that purpose, you have to keep. So every year, seasonal flu vaccine is a must for diabetic. And we have got trivalent and quadrivalent. Quadrivalent is supposed to be better. So we have got now for the past 1 week or 10 days in GH, we are encountering H3N2 strain. H3N2 strain that can be protected by this vaccine. So previously it was H1N1. Now it is H3N2. So empirically also, if you suspect any diabetic coming with dyspnea, you can start on oseltamivir. Status swab, you can start on oseltamivir. So this is the vaccine should be given for all diabetic. But if you want to give as chemoprophylaxis, that is a diabetic has visited an influenza patient or any he has visited. Now when he comes back and he says, I want some prophylaxis, you simultaneously start him on chemoprophylaxis, oseltamivir 75 mg for 10 days. At the same time, you can give a killed vaccine because you should not combine a drug with live vaccine. So you can give a killed vaccine. So you should give simultaneously both. That is for prophylaxis. These are high-risk groups, and now that diabetes comes into high-risk group, and diabetes is considered as an immunocompromised state, but not as much immunocompromised as hypogammaglobulinemia, HIV. So certain live vaccines can be given in diabetic, but this live vaccine, influenza live vaccine, cannot be given. So what are the difference between live vaccine and inactivated influenza vaccine? So live vaccines are available as a spray. It is live. It can be given from 2 to 14 years only. Less than 2 years we cannot give. And diabetic we cannot give. Immunocompromised we cannot give. It cannot be administered with the other live vaccines, or it cannot be administered if the patient is taking drugs. That is oseltamivir or antiviral. So we most of the time for diabetic it is always preferable to give only a killed vaccine, and more than 6 months you can give. And every year you have to repeat it. Influenza vaccine depending upon the strain what WHO announces. And the next vaccine will be hepatitis B vaccine, which all of us must have received during our childhood. But if you are unvaccinated and a diabetic less than 60 years, they have to receive. And not only that, we know now there is a massive, we must have discussed in the essays of today's session. So people who are probably suffering from mast cell, there is a chance that can progress under cirrhosis. So superior hepatitis B may accelerate the process. So they have to receive, and DKD, diabetic kidney disease, RRT, when they are put on hemodialysis, there is a chance for acquiring hepatitis B and hepatitis C. We have got only hepatitis B vaccine. So all these people are absolute candidates for, or eligible candidates for receiving hepatitis B vaccine. And moreover, even if the patient has received in the previous, there is a chance that declines. the antibody try to decline. So based on this, it's better to give hepatitis B vaccine either as a booster if they are not received the 3 series. 3 series is 0, 1, 6 months hepatitis B vaccine. Now we have got Twinrix, that is hepatitis A plus hepatitis B. This is again 0, 1, 6 months combination of Twinrix. Hepatitis A also it's a must when the patient is already having some liver injury. Even one hepatitis A infection which is supposed to be very innocuous otherwise can tilt the balance and push in for acute pulmonary hepatic failure. So you can combine that. Next vaccine is tetanus and that is DPT. So in adult we call it a small d, Tdap and TD. So the difference between small d and big D is pediatric we give as high dose because they require more antigenic stimulus because of the pre-immature response. But adults, because of the boost good immune response, they require lesser dose. That is not only the reason. If we give that capital D to an adult, that's a chance for side effects. And some 3 or 4 years before we had an epidemic of diphtheria, and all our faculties in GH were advised to have diphtheria toxoid, and all of us had, and I was one among who suffered from severe brachial plexopathy. That was the important side effect of myself and few PGs suffered. It took 2 or 3 months for us to recover from brachial plexopathy. So see to that, the reduced toxoid is given to adult. And the recommendation is if they have not been previously immunized, which is very, very unusual. So with they already received DPT in the childhood, it's enough if you give 1 dose of Tdap and every 10 years. Or if the patient has got no prior immunization, 1 dose, then after 4 weeks the second dose, third dose after 6 to 12 months, then every 10 years. So but the first will be the ideal because all of our diabetic patients must have received DPT in the childhood. So every 10 years. So the original DPT doesn't protect you for long time. Despite that, patient have developed diphtheria. And now we have got last again 1 month mumps. Despite MMR vaccine, patient developed mumps. So vaccine is not the panacea, it's not 100% protective. So we have to give booster dose then and there. So next is important zoster vaccination, which has recently been used for the past 2 years, very well available. I will mention the cost also again because all the other vaccines which are hepatitis B and it is less than 100. So the only costly vaccine I will mention the price. This costs around 8,000 to 10,000. It's a single vaccine. So the importance of zoster vaccine is it reduces the incidence of herpes zoster. So once you suffer or you see the patient suffering from herpes zoster, post-herpetic neuralgia, particularly trigeminal neuralgia, some of the patients are even taken up for suicide. So that's the worst complication. So it decreases the incidence of herpes zoster, or even if herpes zoster happens, the incidence of neuralgia, post-herpetic neuralgia is very less if you take this vaccine. So all diabetic more than 50 years of age, because the immunosenescence starts at that time. So even though they must have had chicken pox, the immunosenescence, the antibody, everything comes down, and there's a chance for reactivation, particularly the poorly controlled diabetic. So they have to receive 2 shots of shingles vaccine, or immunocompromised better start more than 19 years of age. And the 2 available right now will be a zoster vaccine, that is recombinant zoster vaccine, which is supposed to be superior to the zoster varicella live ZBL. So what is this? Why ZB is preferred? It is more efficacious. It is ideal because zoster virus live cannot be given for a diabetic. So most of the live virus vaccine cannot be given. It is efficacious in diabetic, in CKD, heart disease. Post-herpetic neuralgia is very much reduced when you use this vaccine. And the important risk is, contrary, the patient has already suffered from GBS, better don't give this, or some autoimmune conditions. Or if unfortunately, if this vaccine is not available and only varicella zoster live is available, you give that for immediate protection. But once this is made available, you have to complete the course only with these 2. So strong recommendation only for this recombinant zoster vaccine, and less track record and less recommendation for live virus. And what about this varicella vaccine? So chickenpox vaccine. So the patient there's no evidence of immunity. Better give them 2 doses because chickenpox in adult is supposed to be very serious, and in a diabetes is supposed to be much more serious and uncontrolled diabetes. So we have to give 2 doses, but it's a live vaccine, so it's contraindicated in certain. So this is one live vaccine that can be given in diabetic, and there are 2 live vaccines available: chickenpox vaccine. This is called post-exposure prophylaxis. But diabetic has seen a case of chickenpox and he wants to protect himself. There are 2 options. So either he can give for vaccine, or he can go for chemoprophylaxis and then later vaccine. So these are 2 options available. And how to go about this? If the patient comes to you within less than 5 days after exposure, he can give this vaccine. Or if he comes after 5 days of exposure, you give chemoprophylaxis right into the midway of incubation period. That is around 8th or 9th day from the source of when he has seen the case. And then you wait, if he doesn't develop any infection, then after 21 days you can give a vaccine for protection, chickenpox vaccine. And respiratory syncytial virus vaccine, this is not available in India, but all diabetics are more prone for this respiratory syncytial virus infection. But if it is available, well and good, one-time single dose. It is a glycoprotein subunit vaccine. It is an mRNA vaccine. So RSV vaccine. And now RSV is quite common in children, and it can produce respiratory distress syndrome. And 2 more minutes. The last is human papillomavirus vaccine. Now we have got 3 types: Gardasil, Gardasil 9, and Cervarix. But the type 1 diabetic females, they are supposed to receive this. Ideal age will be between 10 to 12 years, and this should be given before the first sexual exposure or sexual debut. But certain vaccines like Cervarix can be given up to 40 days. That's called catch-up vaccine. One episode of human papilloma infection is not a contraindication because that doesn't confer immunity lifelong. So it must be give vaccine for all type 1 DM females. And this depending upon that, either 016 or 036, whether it's quadrivalent or bivalent. And COVID-19, all of us do know, there are very many vaccines available. Only this viral vector-based vaccine has increased incidence of coagulopathy because of the adeno component of that vaccine. Otherwise, it is really safe, and CDC recommends one working. And the last is the game changer. This is what we are very much worried. All our diabetics, or most of our diabetics, are prone for recurrent urinary tract infection. So we give a chemoprophylaxis, suppressive dose, whatnot. Now this has come out what's called a Euroimmune vaccine. It is composed of inactivated E. coli, Klebsiella pneumonia, Vulgaris faecalis. It is administered as a suspension under the tongue every day for 3 months. And it has shown very promising results, but yet to be approved by FDA. Once it is approved and is available, it will be really a game changer in recurrent urinary diabetes. With that, I thank for the patient hearing. Thanks a lot.
Thank you, sir. We can have the doubts clarification question at the end of the 3rd session, sir.